Now, I come into the, let us look at the associated conditions that are there along when you have a child with Down syndrome. Most of the systems in the body are affected. Now, we'll take them one by one. Now, talking about the cardiac involvement. Congenital heart disease is seen in 40 to 50% of children with Down syndrome. Could be ASD, VSD, PDA, AVSD, TOF, and combinations of all these things. In literature, AVSD, that is the atrioventricular septal defect, is common, but in our study, which we had here in Calicut, the ASD was the commonest cause of the cardiac involvement. The dominant lesions differ in different geographical regions as per publications from various parts of the world. There's a high prevalence of congenital heart disease and poor sensitivity and specificity of clinical examination justifies routine echo screening in children with Down syndrome, because you're not able to pick up clinically at birth, and there's a high prevalence. So we routinely do recommend an echo screening at birth and confirm it at least by 6 weeks in all children with Down syndrome. So that is what I said, a routine echo at birth and confirm by 6 weeks, and follow up if there's a cardiac problem, depending upon the lesion that is there. It may be at 6 months or maybe at 1 year, depending on what the cardiologist tells you. Advise surgery if indicated. Most of the lesions may be a small ASD or a small VSD, where we can afford to follow up. But if it's a major lesion and a surgery is indicated, it should be done at the earliest possible time. So early correction prevent the development of pulmonary vascular obstructive disease. If that is not done and the child goes into a pulmonary vascular obstructive lesion, there is a pulmonary hypertension, then the surgery at that stage would be disastrous and would not be beneficial to the child. Now we come to the endocrine issues involved. A thyroid disease is seen in 24 to 50% of children with Down syndrome. The commonly seen ones are subclinical hypothyroidism, congenital hypothyroidism, autoimmune thyroid disease, that is the Hashimoto's thyroiditis, and Graves' disease. Now, the subclinical hypothyroidism is the most common variety. You have an elevated serum TSH but a normal free T4. Now, this can be missed if T4-based methods are used for screening. So unless you look at the TSH also, it will be difficult. And if you should look into a free T4, because the T4 as such may be normal, but the free T may be abnormal, but the free T4 is normal. So delayed maturation of the hypothalamic pituitary thyroid axis and the peripheral resistance to thyroid hormones is the reason for this thyroid subclinical hypothyroidism. 50% have presence of thyroid antibodies. Half of these progress to overt hypothyroidism. Now, the congenital hypothyroidism is 25 times higher than in the normal population. You have an incidence of 1 in 150, and it is basically due to thyroid hyperplasia. It is not always picked up in newborn, except you go in for a repeat screening at 3 months or 6 months. You have to follow it up at 1 year and every year thereafter, even if the tests are normal. The TSH and T4 cutoffs are the same as in any general population. Autoimmune thyroiditis, there's a high prevalence. Both hypo and hypothyroidism are commonly seen, but hypothyroidism is more common. You have anti-TPO antibodies, they are very high and they reflect upon the autoimmune thyroiditis. Now, checking up what it is, the thyroid function test. You do a full TFT, especially at birth. So if the child is euthyroid, that is the thyroid values are normal at birth, you repeat it at 6 months, 12 months, and every year thereafter, if they are normal. If they are abnormal, you will have to start on a thyroxine drug and then repeat it more frequently. Now, this is a dose of thyroxine, levothyroxine 10 to 15 microgram per kg per day in the newborn and less than 1 year. Free T4 and TSH after 4 to 6 weeks. So after starting the medicine, you want to repeat it after 4 to 6 weeks. The dose is adjusted based on the values, and thereafter it should be done every 3 months. The follow-up should include all physiological and developmental parameters. Now, in autoimmune thyroiditis, at 1 to 3 years, you give 4 to 6 micrograms. 3 to 10 years is 3 to 5 micrograms, and 10 to 16 years, it is 2 to 4 micrograms per kg per day. In Graves' disease, you give carbamazepine 5 milligram. You give the dose is 0.1 milligram per kg per 24 hours. There are associated autoimmune disorders along with that. When you have this, they are alopecia areata, where a small portion of hair is lost over the head of the scalp, vitiligo, celiac disease, type 1 diabetes, and abnormal AIERE. Growth issues. So the growth problems are there's a defect in growth acceleration that leads on to short stature. You got to use Down syndrome specific growth charts to monitor the growth of children with Down syndrome. The growth velocity significantly is reduced between 6 months and 3 years. There is no overt growth hormone deficiency. There is selective IGF-1 deficiency in Down syndrome more than 2 years of age. You got to rule out hypothyroidism and other skeletal abnormalities before evaluating for GH-IGF axis to find out that the other conditions are taken care of. Hypogonadotrophic hypogonadism, you have a high level of LH and FSH. The concentration of sex hormones are not very low. They're almost normal, even though you have higher levels of LH and FSH. The pubertal progression is slightly delayed, but the rate is as for normal individuals. Fertility is possible, especially in the females, but the rate of that is also less. There's increased incidence of overweight and obesity. There's a nutritional deficiency and higher fat mass index and lower lean mass index in the DXA scan. Now coming on to the gastrointestinal problems. You have the embryological or structural defects where there's esophageal atresia, tracheoesophageal fistula, which can be 1%. Duodenal or genuine atresia, you have it about 247 in 10,000 live births. Annular pancreas, anorectal anomaly, and Hirschsprung's disease. And you have the motility and coordination problems like feeding difficulty, poor oromotor function, gastroesophageal reflux, constipation, toddler's diarrhea, gallstones. Well, there are a lot of conditions that are associated with Down syndrome as far as the GI tract is involved. Autoimmune conditions, you have, as mentioned earlier, celiac disease. So 5% of children with Down syndrome do have this, and hence screening is recommended, more so in the Western world. If the screen is positive, go in for a biopsy and then manage with a gluten-free diet. Malabsorptions are also common. There can be a deficiency of vitamins and minerals, and it may be prudent to supplement them with vitamins and minerals. Well, the recommendations are complete physical examination, including anal patency at birth, ask for history of passage of meconium, record weight and height in a Down syndrome growth chart. Now, this is very important because of what I mentioned. The growth velocity is not as per a normal child. But if you don't have a Down syndrome growth chart, you can use a normal growth chart, but then you should take this into consideration because it shouldn't be taken as a decrease in velocity. It's part of the growth pattern of a Down syndrome. Test for celiac disease if symptomatic. Now, this is a recommendation in our country. If symptomatic, you test for a celiac disease. Bone health. There's a low bone mineral density. The low physical activity is responsible for that. Less exposure to sun, obesity, and less food intake, basically. So the calcium intake is also less. There's a decreased muscle mass associated illnesses like celiac disease. Drugs, especially if you're on anticonvulsants or other drugs, there could be deficiency in that and lead on to low bone mineral density. Renal problems. You have the congenital anomalies of the kidney and urinary tract. You have the renal agenesis, microcyst, ectopic kidneys, undescended testes, hypospadias, epispadias, and you have the obstructive lesions of the urinary tract like hydronephrosis, hydroureter, posterior urethral valve, obstruction of the anterior urethra. With increased survival of children with Down syndrome, it is noted that they're going to have a larger number of them going for a chronic renal failure. The glomerular disease occurs in the second and third decade, mainly IgA nephropathy. The immune dysfunction is there, post-infectious glomerulonephritis. Urodynamic involvement, 30% of children and 8.7% of adults do have this problem. There's a delayed sphincter control and incontinence. Hypercalciuria, cystinuria, and uricosiria are noted. And there's a larger incidence of testicular tumors. The risk is 6 to 50 times higher than in the general population. So the recommendations are routine screening is not recommended, but a thorough physical examination is mandated. If there is an abnormality in the anomaly scan that was done prior to delivery, there should be a postnatal follow-up. Further investigations is as for any other child, depending on the signs and symptoms. You can go in for all the UTI investigations as for any other normal child. So that's the end of session 2. Now, session 3, we go into the hearing problems. There's mild to profound hearing loss. It affects more than 50% of children with Down syndrome. In childhood, it's otitis media with effusion, and in adulthood, it's a sensorineural hearing loss. And children have speech and language difficulty. They're affected either because of otitis media with effusion or sensorineural hearing loss. Obstructive sleep apnea is there. A chronic rhinosinusitis and adenoid hypertrophy are noted. The orofacial and craniofacial maldevelopment occurs. The inner, middle, and outer ear problems are responsible for all these. So the recommendations are, you have a neonatal screening, basically OAE, that is otoacoustic emission test, and a full audiological assessment by 6 to 10 months. You do a BERA, or later on you do an audiometry. Audiological evaluation is repeated at 18 months. It's reviewed every year till 5 years, and thereafter 2 yearly after 5 years. There should be regular dewaxing because they have a shorter canal and wax sort of completely occludes it, and that can produce a conductive hearing loss. Grommet insertion if there's otitis media with effusion, and adenoidectomy. Cochlear implant can be done for severe sensorineural hearing loss. It is found to be equally good as for any other normal child. Ophthalmic problems. You have a high incidence of ophthalmic problems. That's almost 60%. This can be a congenital cataract, a developmental cataract, nystagmus, and congenital glaucoma. Nasolacrimal duct obstruction occurs in 10 to 36%. Refractive errors is 10 times more common, and blepharitis in 30%. Strabismus or squint in 25 to 30%, and keratoconus can occur in 15% of children. So the recommendations are a newborn eye examination in 4 to 6 weeks, reviewed at 18 months to 2 years, and at 4 years, that is 2 yearly after 2 years. So check up at least every 2 years for life, because there can be changes. They can go in for myopia or any other keratoconus or cataract or any of those things, so it shouldn't be missed. Dental problem. The basic problem is a large tongue with marked fissuring, so there can be food impaction and halitosis. The tongue is protruded, is purely developed maxilla. There can be dental malocclusion and malalignment, microdontia and hypodontia, and enamel hypoplasia. There's hypocalcification of the teeth, delayed primary dentition, and permanent teeth that is delayed compared to the normal child. So low prevalence of dental caries. Periodontal disease occurs in 60 to 90%. Poor oral hygiene, gingival hyperplasia, gingivitis, and chronic periodontitis. So prevention of caries and gum disease, brush twice daily with a soft toothbrush and a fluoride toothpaste. In children less than 2 years, a thin smear of toothpaste, fluoride paste is all that is required. And in children 2 to 5 years, a small pea-sized amount can be used. Floss daily, even though it is recommended, it may not be practical to floss daily, but it is preferable that you floss daily to prevent dental caries occurring later. Limit sugar and refined food. Recommendations are first visit at 6 months or first tooth eruption or by 1 age. The first tooth eruption may not be at 6 months as in normal children. It may be delayed up to 1 year. So that is why the recommendation is 6 months of first tooth eruption or at 1 year of age. There's a yearly dental review after that. And the delayed dentition, both primary and permanent, can be there. And orthodontics, that is the braces, can improve the malalignment. Dermatological, alopecia areata, 6 to 10% of the alopecia areata. It can be associated with vitiligo, hypothyroidism, and trachonikia. Hair growth is impeded by a low serum ferritin, cirrhosis, seborrheic dermatitis, irritant and allergic contact dermatitis. And this can be acanthosis nigricans. It's a marker of insulin resistance, as we all know, that is associated with obesity. Pustules, nodules, and abscesses in the armpits and groin are noted. Folliculitis, furunculosis, impetigo, scabies are more common. There's accelerated aging, graying, thinning of hair, skin atrophy, wrinkles, and lentiginous. So here the recommendation is a thorough cutaneous examination at first contact and subsequent follow-up visits, with particular attention to scalp, axilla, groin, and feet. Skeletal system. This atlantoaxial instability is seen in 10 to 30% of children with Down syndrome. Hip dysplasia is common. There can be slipped capital femoral epiphysis, avascular hip necrosis, recurrent joint dislocation, especially of the shoulder, knee, elbow, and thumb. So the recommendations are atlantoaxial instability, check clinically, a physical examination at each visit. Also ask for a history of any numbness or difficulty in walking or any of those things associated with a compression of the spinal cord. Incidence is 10 to 30%, mostly asymptomatic. Only 1 to 2% are symptomatic. Routine screening by an X-ray is not recommended now, though earlier it was recommended at 3 to 5 years it should be done. Now the recommendation is to do an X-ray only if the child plans to participate in contact sports and if there are neurological symptoms. Anesthetic involvement procedures can also have a problem. So if required, pre-anesthetic checkup can also include the stability of the atlantoaxial joint. Hematological, transient myeloproliferative syndrome, the incidence is 5 to 30%. You have a leukemic-like reaction at the time. Now the recommended terminology is transient leukemia in Down syndrome, TLDS, instead of the term transient myeloproliferative syndrome. The reason is there is a risk of leukemia, though small, in children who have it. And then unless this term is used, you may ignore or you may miss the follow-up of leukemia. The clinical features are hepatosplenomegaly, skin rash, pericardial and pleural effusion, extreme leukocytosis, and coagulopathy. AML, acute myeloid leukemia, and ALL are common, and you have an increased incidence of nutritional anemia. And as you all know, anemia can add on to cognitive developmental delay. Puberty. There is hypergonadotrophic hypogonadism, as mentioned earlier, with a high FSH and LH due to Sertoli and Leydig cell dysfunction. There's no delay in puberty. There can only be a mild delay, but no significant delay in puberty. Have intimacy needs and sexual feelings as in any other child. Now, this is something we should be careful about. We should know that just because as a child with Down syndrome, many people believe that they don't have any sexual feelings and they don't have any feelings, need for any intimacy, but they do have it, and maybe because they know to express it properly. Females should be educated about their monthly periods and how to handle them. So that's the end of session 3.